This presentation is about the foot, ankle, and lower leg injury assessment. This would be a secondary assessment. So my goals for this presentation is obviously to teach you about the steps for doing an evaluation or assessment for the foot, ankle, and lower leg. I have a handout for this presentation. Just a couple things. If we are on campus and taking this class, we would do this class in campus. We would actually touch each other. We would do the actual hands-on portion of this lab. But since we're doing this online, we just have to make this work. Now, the other thing you'll see in the handout, I'm not following the HIT process for doing an injury evaluation. This is my steps that follow more of the HOPS or the HIPS secondary evaluation process. And I just wanted to let you know that up front. And this is probably a lot more advanced than you would actually should have in this class. If you go on and continue your education to become a certified athletic trainer or a physical therapist or nursing or whatever particular medical field that you may go into, you'll go do this evaluation process again at your professional program. So let's get started. The first step is understanding the mechanism of injury and history. What we're trying to do here is we're trying to get information to understand what happened. Okay. The type of information we're getting during our history phase, we want to go from general questions to specific questions. You know, what happened? When did this happen? What was the position of your foot and ankle when you got hurt? Those type of things. You want to be, you're trying to determine what happened. So what's the mechanism of an injury? Is it this acute or chronic injury? Again, in this step of our injury evaluation, this is the step that takes the longest to understand how to do. It's the most important step of our process. We're trying to be like a criminal investigator, we have the big picture, and we're trying to narrow this down by asking questions. You want to ask general questions before you get more specific. And some of you probably, if you've been injured, somebody will ask you, can you point with one finger where it hurts the most? One of the reasons why in the lectures I go over all the mechanism of injuries, because that's what a patient will tell you how it happened. I rolled my ankle. I changed my training program. So you have to ask that question. Have you recently changed your training program? Let them answer that question. Can you describe your pain? Is it dull, achy, sharp, shooting? Those type of questions. So this takes some time to learn how to ask those questions. And after a while of becoming when you're a student and then when you're working as a professional, you start developing a list of a bunch of questions in your head that you know to go for and answer and ask. And you know that when they answer, that's kind of chipping away, what's my injury here? What's my condition? Our next step is bilateral observation or visual observation. Bilateral means looking at both sides. So you're going to look at the good side versus the bad side. We examine the gait, that's walking. Can they walk without pain? Are they limping when they walk? Are they favoring one side or the other side? When we are doing our observation, we're looking for claw or hammer toes, hallucis valgus, any hallucis callus blisters. Now, hallucis valgus is when the big toe goes in. Hallucis callus is when the little toe goes out. You also want to look at the medial, lateral, anterior, and posterior for any deformities, signs of inflammation, which are again the redness of the skin, swelling, discoloration. Atrophy means muscle is gone down, it's shrinking. Can you see any surgical incisions? You also want to look at their shoes to see if their shoes are wearing funny. Those type of things. We're looking for anything that can tell us, give us clues for that particular injury. Again, we're going to compare the good side to the bad side. Our next step after we do our visual observation is we're going to do palpation, which means touching. I've provided you videos about how to do this because I think it'd just be easier to show you this through a video. So that'll be in this in the class. Typically, want to palpate soft tissues first, and then the bones, and we're palpating for for pain. So when we touch it, does it cause pain? Muscle tone, because the muscle feels different when it has swelling and there is no swelling, and skin temperature. And we also, should be bilateral palpation. Again, we start with the uninjured side and we want to compare it to the injured side. We want to start away from the injured area and with gentle pressure, then work our way towards the area of injury or pain. And again, start with gentle pressure. Part of this is to build confidence with the patient, because you don't want to go straight to the area of pain. Say it's an ankle injury, you don't want to go right to the anterior talar fibular ligament and push down real hard. You're going to scare them and they're not going to trust you anymore. So part of this is just building some trust with the person. On the handout, I have the next step for the lower leg, ankle, and foot is test for fractures. We talked about this in the foot, or in the ankle and lower leg lecture. So we have the test for fracture, the bump test. Again, you bump the calcaneus, and positive sign is pain with the bumping. Again, you want to start with light pressure and increase your pressure. Again, this is a little bit more advanced for our particular class, but still just good to have some information. The compression test is squeeze the tib and fib together. Again, start away from the main side of pain and work your way towards that. If there's pain, that's the positive sign. And if you think they have a fracture, you're at this point in your evaluation and they're having a lot of pain when you're doing any of these two things, I would just stop your evaluation and they need to go get an x-ray to make sure to rule out a fracture. Our next step in our evaluation is range of motion testing. So we have active range of motion, which is AROM. That's where the patient moves the body part on their own. Then there's PROM, or passive range of motion testing. So that's when you move it through the range of motion. That would be like stretching. And then there's muscle testing, which is resistive range of motion testing. And this is how we're testing the primary movers. We would have the person do a plantar flexion with the good side first and dorsiflexion on the good side. Then you would compare that to the injured side, have them plantar flex and dorsiflex, and see if they have any decreased range of motion. Then with the strength testing, the resistive range of motion testing, again we start with the good side, and you have them push against your hand when they're doing plantar flexion. Then you cup around their foot and have them pull their toes towards the shin to test for dorsiflexion. And you can do the same thing on the injured side. You do the same thing with inversion, eversion. Do with the big toe, little toe, all the toes. More advanced stuff we can do with this is we can actually measure the angles of their range of motion, how far they are doing flexion, extension, plantar flexion, dorsiflexion, all those type of things. With what's called a goniometer. Again, that's a little bit more advanced for this particular class. But these are the range of motions and primary movers that are used for each one of the range of motions. And again, it's on your handout for the class. Next one is stability test. These are special tests or stress tests. There's all different names for the same thing. If you want to see how these are actually done, search YouTube and they'll have various videos for these. We've talked about this in the lectures too. So we have the anterior drawer test, and it's for the ATF and the CF. Patient is neutral, hanging off the table like picture shows. We stabilize the lower tibia and fibula. We draw the heel like a drawer, and the calcaneus or talus moves forward or up. And the positive sign is the talus slides anteriorly or forward. So that means there's laxity. You can actually hear a clunk or feel a clunk sensation, and that patient's going to have pain. This is a very common test in athletics and in physical therapy, and doctors do this. Orthopedic doctors will do this test. So that's anterior drawer test. Next one's the Taylor tilt inversion. This tests the calcaneofibular ligament. Again, the ankle's hanging off the table. It's in a neutral position, which is called the open impact position. We're going to stabilize the tib and fib, and we draw or move the ankle with an inversion stress. And the positive sign here is the talar tilt has more laxity than on the other side. So you're going to do the good side first with all these tests, then go and do the injured side. Injured side, with the positive test, the ankle will invert more than on the uninjured side. And pain is another positive sign. Now we can do this with an eversion. Again, we're checking the deltoid, same position as we did with the other side, but we're going to use eversion force. And again, positive sign is that it has more laxity than on the uninjured side. Klinger's test is again for deltoid, and so you can see the patient has their leg hanging off the end of the table with the ankle in neutral position, and we externally rotate the ankle, and again the positive sign is there's more laxity and there's medial pain. We can do this for our syndosmosis or for a high ankle injury, high ankle sprain. We do the same position as the Klinger's test, get my brain working right. But place the ankle in dorsiflexion, then externally rotate. And here the pain will be on the front side of the ankle, right where the anterior tibial fibular ligament is at. So between the tib and the fibula, that's where that pain would be at. Last test we're going to talk about is the Thompsons Test. This is for an Achilles tendon rupture. So the athlete is lying prone or on their stomach on a table with their feet hanging off the end of the table, and we squeeze the belly of the calf muscle. Then while it's relaxed, normal is plantar flexion when we do that, when we squeeze somebody's calf. You can do this on somebody to squeeze their calf when they're laying on a table like this, and the foot should plantar flex, the ankle should plantar flex. If it doesn't plantar flex, that means that Achilles is ruptured. Our next area is neurological testing. This is I have this more information in the handouts here. This is a reminder here. This is we're testing the spinal cord area. And I have some links in the class that explains this a lot better than I can. But we can test myotones, reflexes, and dermatones. So a myotome And all this information is from physiopedia.com. A myotome is a set of muscles that are innervated by a specific single spinal nerve. And so we know which muscles are getting signals from the spine by doing these different tests. Like, for example, we know that at L3, which means lumbar level 3, that's the quads or knee extension. So we can test the knee extension if a person has pain with knee extension and we thinking they have some kind of nerve back injury. We know what specific area in the back is involved by the muscle testing. Next one is reflex testing. You probably all had reflexes tested on yourself. This is an involuntary and nearly instantaneous movement in response to a stimuli. You probably had the knee when you lay on or you sit on the edge of the table and the doctor or the nurse hits you with that little plastic hammer at the patella tendon and your knee jerks. That's, again, we know by the level, if you do that, like that particular test that I just talked about is L3 and L4. If you don't do that, you have it on one side but not on the other side, we got some issues with that particular area in our spine. Dermatome is the area of skin that is mainly supplied by a single spinal nerve. So on the sheet, the handout, L4 in our back is the medial leg and foot, so we can test that. Again, this is more advanced for this particular class. This would be if you're in a professional athletic training education program, nursing program, medical school, physical therapy, occupational therapy, those type of things. This is what you learn how to do. Our last process or test is functional test. We have walk, run, jog. We go first they walk, then they jog, then they run. We do straight, and run circles, run zigzags, figures of 8, Z cuts, some of their athletic movements, if they're whatever sport they're doing, have them actually do their position, jumping, all those type of things. Anything that they would do in their sport. Squat with both feet, and then with injured limb only. And as I said earlier, do sport-specific activities with them to see what causes pain and what doesn't cause pain. And as a review, so if we were using the HIT evaluation process from the textbook, H stands for history. So in this process that we just that would be understanding the mechanism of injury and the history step. I would be inspection. For what we just went over, that would be the observation step. T is touch, so that's the palpation step. HIT doesn't have these following steps: muscle testing, stability and special testing, the neurological, or the functional test. So again, my process is a little bit more developed. I developed all this stuff when I was a student, and I just took it into all my coursework because I wanted to have a way for me to break down the evaluation in more detail for myself. And so this is how, as a clinician, how I would do my evaluations for an injured athlete with the foot, ankle, and lower leg.